he came back in again, and it was really baffling because the same probably ambulance center sent him back this time, and he was just had terrible meningitis, encephalitis. I couldn't understand it. He did have a fever. I couldn't understand what was going on. And so back then I said, well, we got to get, I don't know whether we got a plain skull film or whether we got a CT scan. But when we looked at the image, there was air in between the convolutions of his brain. Dr. Bhatti and I get together now and then, and here is an interesting story I've encountered over the years. When I was chairman over at Creighton University, I worked very closely with the neurosurgery people because we shared a lot of patients. We helped them and they helped us, and we got to know each other. Besides that, we were on the same baseball team, so that kept us close. Anyway, one day an ambulance came into the emergency room because a young man had a gunshot wound to his head. There was on his left side. Now I'm going to touch my left side, but it'll look like my right side. So on his left side, there was a hole, I don't know, maybe about this big around right here. The problem was he was very despondent, and he put a shotgun into his mouth and pulled the trigger. And at the last minute, as he pulled the trigger, he pulled the barrel one way so that he didn't take out both eyes. So he lost his left eye in the process and some of his frontal lobe. And I don't know how you manage a problem like that, but he came from about 100 miles away from here. And when Dr. Taylor, I think he must have been in his 20s.
20s. And so he shot with a gun in his mouth.
Uh-huh.
And at an angle so that he lost his left eye.
Yeah. So yeah.
The bone, everything is gone.
Yes, but the eyebrow was still there.
Oh, eyebrow is there, okay.
And the forehead is still there. But
But
it
the
took out
eyeball was taken out.
Well, it may have been just the optic nerve that was taken out. I'm not really sure, but the eye had to be removed. So anyway, if you ran across,
he went to a local emergency before, or he was just driven 100 miles to you guys?
I don't know. They probably took him to a hospital and they said, get him in an ambulance as quick as you can. I don't know how they stopped any bleeding, and I don't know how many units of blood he got on the way. But when he arrived, you have to make a split decision. Is this salvageable? Is this man going to really want to go on? And you don't know. So he just did the best he could, took him to the operating room and tried to patch him up, stop the bleeding. And the question was, how are you going to close the hole that from the top of the head, looking down, you can see his tongue. And so you have to cover that space with something. So they took tissue from the thigh, and they call it tensor fasciolata grafting of his own. So, by the time that is healed, he'll maybe or maybe not be alive, but they did the best they could.
And it was like a roof cover that they put in so that the stuff from the mouth doesn't go up into the brain.
Exactly.
So fill that space. Yeah.
Yes, and vice versa, because all this was contaminated. There's nothing about a shotgun blast that's going to save anybody.
What was the plan for the top of the head? Just close the skin, leave the skull?
I think the scalp you can pull together. I don't know where they got the skin for that. Sometimes they take it from the back or some other, or the belly or some part of the body. And there was a time when you took out let's say, or somebody that this is a different kind of a problem, there was a time when you had to remove part of the skull to get a subdural out, or if there was a large shift and you didn't know where to put this, some people used to put it in the refrigerator or something, but then somebody might throw it out or misplace it. So they used to put it in the abdomen, just cut some skin there, put the bone right in there and close it up. And then when they want to put it back in, they would wire it back in, but they would take it out of the pocket they put it in. So anyway, this is all off to the side. So they're treating this young man, and they also noticed that they were trying to seal everything up, but he kept on getting spinal fluid coming out his nose, which is a bad thing. So you have to use antibiotics and hope that the flow keeps going, because if the flow coming out slows down, then the bacteria can go in. And there's bacteria all over the place in the nasal cavity and the sinuses. So eventually that stopped. And so everybody sort of exhaled again. And when he woke up, he was determined to live. He wanted to live. And he may have lost some of the frontal lobe that makes him worry or something, but he was, from then on, a really fine young man. The problem was a girlfriend went out with another boy or a young man, and he thought his life was.
Sounds like he had a frontal lobectomy, and that can cure depression. Not that we promote treatment like that, but
well, they used to do that with some people. They used to, you know,
put like a wire from the top of the skull and just cut the frontal lobes off, right?
Yeah.
Well, those patients used to become more like a zombie and have no.
Yes, they were very flat affect, but this
like
guy
he only lost one frontal lobe, right? He still had the other frontal lobe.
Correct, and he got partially back to the speech area. So it was, you can sort of tell by what he had trouble with. He had trouble with speaking, so he could understand you pretty well, but speech itself for him was difficult, and he had a hemiparesis on the other side. So
he had
exactly a motor aphasia. So when you asked him a question, he might say, you might say, "How are you feeling?" And he'd say, I'm feeling good. Like that. He would, like a lot of Broca's aphasia, he's telegraphic. He doesn't elaborate like I do all the time when I'm talking. But anyway, so then he was turned over to me for my care. So I found out that he had a tendency toward seizures. So I gave him medications for that. And then he got better and better, and he came out of the ICU and was in the hospital, regular hospital rooms. And then we sent him home. And it got to the point where we got to be really good friends. And, people sometimes caution doctors, don't get emotionally involved with your patients, because you should have equanimitas, like Sir William Osler. And it's good that you have to be aloof, because it can really wear you down and be very depressing to see so many casualties, like in Syria and Turkey these days. All those people in the rubble, and it's just awful. Anyway, it can be really tough on you, but I feel that if you get your emotions involved, then you're more likely to really care and do the best you can. So it's an argument that you can have with yourself or with others, but nevertheless, he got better. And I found that if we engaged his other hemisphere, the one that wasn't affected, and we sang songs together, we liked to sing Motown songs together, he and I, and we used to sing The Way You Do the Things You Do, or Smokey Robinson was a favorite. And we just would sing songs together after we got the work done. Yeah.
Was his singing better than his speech? Sometimes people with expressive aphasia
yes
can sing songs,
he was able to sing a song better than make a sentence. Yes. So, you learn a lot the hard way from such patients. But anyway, so we sent him home, and I would see him every 6 months for a while, and then every year. And then about 2 years later, I mean, this is a long story. So I don't know how many cups of coffee. Okay. All right. So anyway, there used to be somebody standing off to the side when they, on a movie set, would say, hurry up or something like that. But okay, so then he came back in again, and it was really baffling because the same probably ambulance center sent him back this time. And he was just had terrible meningitis, encephalitis. I couldn't understand it. He did have a fever. I couldn't understand what was going on. And so back then I said, well, we got to get, I don't know whether we got a plain skull film or whether we got a CT scan. But when we looked at the image, there was air in between the convolutions of his brain.
That was 2 years later. He came back 2 years
About 2 years later. And so I tried to figure out, there's air in his brain. How could the air come in? Because the covering over the scalp was okay. That was intact. And then I asked the family, and they said, he's been sneezing a lot and blowing his nose. And I said, he blew his nose too hard and blew through the patches that we put in before to keep the CSF out. You know what I mean? So it went the other way. So he had all this snot and infectious stuff because, our mouths and our nasal passages and our sinuses are full of junk. So we gave him antibiotics, and he was in the ICU a long time, and he finally got over that. And I finally he remembered that he was having a cold and was blowing his nose. I said, well, only blow one side at a time, or don't blow at all. Just, stop doing that. And we saved him, and he went back. So there
you
was
got IV antibiotics and things like that.
Yeah. Oh, yeah. Oh, we had to change him.
Did you have to do resurgery of that roof of the mouth or something?
No. It just we didn't have to go in again and do more surgery. It was I guess it must have closed itself. I don't know. But and he did quite well after that. Actually, he was working. He was employed. They gave him one of those wide brooms, and his job was to sweep the floor. And when you saw him walk, you could tell he kept one arm up, and he did have a hemiparesis. It would be on his right side. So anyway, but he was, the examinations I compared with the ones before, and they were about the same. So it was another save. So that's the second time we saved his life. I didn't know about this, but I found out the fourth time, or sometime later, that he had some other problems. If you have one problem, that doesn't mean you're never going to have other problems. So he had GI problems. I don't know exactly what they were. I'm talking with the family because he actually may want to have his story told. Anyway, so this third time, he was taken into an emergency room for GI problems, and they found out that he had Henry Lynch syndrome, which is hereditary cancer of the GI tract. Henry Lynch was a fantastic, amazing guy at Creighton University. He was a pioneer because he found patients that he was in genetics, and he was an ex-boxer, big man, and he would be running. I could see him running down the road sometimes in the morning when I went into work, because he would do what he called road work, because he was, like boxers do, they run and they punch the air and things like that. He was just a big man, but very intelligent, wonderful person. Besides being the leader in the world, he was known all around the world because he traveled everywhere to do these genetic family trees. And he found out when he presented his original hypothesis that some cancers are hereditary, people thought he was nuts. But he has 2 Lynch syndromes named after him at least. And so this guy had that problem, and they took out his cancers and he survived. They got them all. And I don't know if he needed chemotherapy. I wasn't involved in that. So then I've been following him once a year, and I always do one of our careful neuro exams that we did together.
Yeah, that we have on our YouTube with about 5 million views. So do you have a rough idea of when he had to go through this cancer chemo after the first incident? 2 years later, he came back with a brain infection.
I don't know. I would guess it's several years.
Several years, okay.
Because I saw him recently, and he's now 51.
Oh my gosh. Has been your patient for nearly 30 years?
Probably close to 30 years. Yeah, as long as I've been here in Omaha almost. So
Okay.
Anyway, so I wanted to make sure that I got a chance to see him, even though, we're in movement disorders. This isn't really a movement disorder, but he's somebody that I just have to make sure he's doing okay. So he was scheduled to come in, and I talked with our nurse, and I made sure that she got him scheduled. So he had to postpone the second last day of my clinic. And so I insisted that we find a place for him. So we had him come in on my last day. And he's there with his stepfather, who's always been a father for many, many years. So I don't know, he's probably taken care of this patient at least 20 or more years. And his mom was there too.
So he came back to see you after a year or 2 or something like that?
I've been seeing him once a year.
Right.
All this time. So I've probably seen him, I don't know, 30, 40 times.
Yeah.
You put it all together. And so I know him pretty well, and we do sing songs together at the end. And we are really good friends. And, it's good to see how well he's done. And when I told him, I just got to let you know I'm going to be writing your story, but I'll change the name so that nobody can tell exactly who I'm talking about. And he said he would like me to use his real name.
Mm-hmm.
So I said, well, I have to get probably authorization in writing and things like that, but
right.
We are that close. So when I talked to him, it's about a month ago now, I noticed he wasn't quite as quick on the uptake as he was before. I didn't know if he was just taking all his medications right or whatever. And I think he did have a small seizure within the last month. So, and then I found out, because of his injury, he has a right hemiparesis. And so, and trouble feeling on that side too. I don't know exactly what pathways have been affected, but I found out that he couldn't feel light touches on either foot, which didn't make sense from that injury. So I asked if he had any history of diabetes in the family, and no, in fact, he isn't very filled out. I think he has lost a little bit of weight. So everything else was okay. He wasn't sure what day of the week it was, but a lot of people who don't have to know don't know. So it was just minor things, but I just decided I think we're going to have to draw a blood test. And I just said, I think we should get a vitamin B12. And I didn't know exactly what made me say that, but it's something fixable, unlikely to be vitamin B1. It's much more rare. So the next day, my last day, the nurse called up just as I found out his vitamin B12 level is really low. And I tried to think, well, why is that? And it was a good hunch that I had, because this is the fourth time that we saved him. When we, meaning the healthcare system.
Right.
And this guy is inspiring, I don't know, to me anyway, that somebody can put up with this with such grace and with such courage. And he was asking me what I was going to do, and was concerned about what I was going to do in the future. So he's really very intact in many, many ways. So I even called the family up and made sure that he was getting his vitamin B12 shots, and he wasn't yet. So I again had to push. It's another important thing to double check, because you think everything is done and you told people to tell people to get his shots, and he hasn't had them yet. So I made sure this time, and I talked to the stepfather at length about it, and you may be seeing an interesting story in the future if I can get my act together and write these stories down. So there's an example. If a cat has 9 lives, how many humans have 4? You know, because if we had missed this one, you know what would happen. He would lose feeling in his feet. He would probably have trouble walking. He would likely fall. He would become demented and non-compliant. And that would be an awful ending to this story. So that's a patient that I feel really privileged to be part of his care, because all the things that I learned and all the worry and double checking are the antibiotics still working, all those kind of questions. I guess I'm too far away and you're noticing that. But anyway, so that's the story. Can I elaborate, or did I leave something out? Yeah.
No, I think this was pretty good. I think, I was thinking about it, that one of the risks that I see that we have as physicians, that sometimes we just write off things based on someone's history. Someone comes in who have had strokes in the past and is now, walking a little slow or thinking a little slow. We say, oh, yeah, this guy has had stroke before.
Yeah.
Or he has had his brain blown out and things like that. And we ignore early signs like confusion or dementia or walking, which could be something else going on. And I'm glad that his Crohn's, his Lynch syndrome and gut cancers were not written off because of his prior history and things that has happened to it. By then he has had meningitis, he has had seizures, he has had brain stroke or traumatic brain injury, and I worry about that in my clinic all the time, that we have such a short time with patient, 20-minute follow-up, and with patients who have established with you for 20 years, you become a little casual with them. Or even a new patient, if is transferring from another physician who has a diagnosis or a history, say, oh yeah, this is just Parkinson's disease. And that's a big challenge. And to catch something over and over again in a patient, you have to always see with a fresh set of eyes.
Right.
And
Yes.
That's difficult.
Well, we have a differential diagnosis, which is a funny term for it. In other words, we have to look at all the possibilities. But there are different ways of going about this. If you walk down the street and you see a man collapse laying on the ground, okay, there are ABCs. The first thing that you do is make sure he's still got a pulse. Then you try to make sure he's still breathing okay. And then you check other things. But if you don't check for the pulse, you can be usually correct all the time, but he's going to die in front of you if you don't notice that. So some differential diagnoses are what can cause death immediately, and then what can cause death a little bit later. And then, you go down the list and you make sure that you're not missing the most important things. There's another differential diagnosis, like what's the most likely thing? And that's when we say, oh, the guy's got Parkinson's disease, he's stumbling, he's going to fall someday, and we have to watch out for that. And we have to check vitamin D to make sure his bones are strong enough, just in case he falls. But what if he's got something treatable like a B12 deficiency or B1 deficiency, B6 deficiency, thyroid disease, hypothyroidism? There's so many things that can cause neuropathies. You know, there's probably a list that's never going to stop growing of causes of neuropathy. So there's that one, and then there's the most likely diagnosis, you know. But there are times when you have to really think outside the box, because what's important to the patient is this fixable? And I think you're not going to fix the wound that he had. You're not going to fix the removal of the cancers. And then it occurred to me, well, there's lots of reasons why he might have a B12 deficiency. They might have taken out the terminal ileum with the cancers. I don't know. So it may be worth it when I get outside records, and if I want to really write this case up well, I have to find that out. There probably is an operative report somebody did, or I could look through the pathology and see what parts of the intestines were removed. But yeah, he may have had a terminal ileum out, or he may not be eating the right kind of foods because maybe his olfaction is gone. Maybe, you know, it took out the upper parts of the, maybe both olfactory nerves were affected somehow. I don't know. I mean, because he had operations to patch things. Lord knows what could happen. I think you're right. We sometimes get too casual. I remember early in my career, there was somebody I was sharing a patient with. He was being seen at Johns Hopkins University as well. And I must have been in Philadelphia then, because it's fairly close. Anyway, I often wondered why he was always looking for other reasons for what seemed obvious to me. And I have learned from that person that he was, I think, involved in peripheral neuropathies, and he was always looking for something treatable or something else that might do the same thing. And I have learned a lot, because if we're doing a review, as we spoke earlier, and find that 8% of the times that we check for vitamin B1 are actually abnormally low, then that's a lot higher prevalence in our cases than I would have imagined. So, and these are not just cases, these are each time we order the tests. So we're going to do a lot of research into that now. And, you know, we've worked with the Parkinson's study group, and I would like to see every patient that's now going to be in a multi-center study, they do blood testing beforehand to make sure that the red blood count's okay, hemoglobin's okay, and other things as well. But if we do a vitamin B1 and a B12 at the start of the study, and then every year they're in the study, we check it again. My belief is that it's very common for people with chronic disease like Parkinson's disease to eventually not eat well because they don't have olfaction. They go for the sweet things and not the tasty things, and they may get vitamin deficient as well. And if that's something that I miss on my watch, I am not going to be a happy camper. I want to make sure that my patients, we give them what they need. And I think every general practitioner should do the same thing. When a patient comes in for an annual checkup and they're getting up in their years, well, you should think about what are the 5 most important things that can really cause problems this next year. It'd be cardiac disease, stroke, cancer, falling. I mean, there's a lot of things. Dementia. You may want to just double check and make sure that things aren't sneaking up on you. But so often, they go through the motions and whenever I'm a bad patient. First of all, I don't like seeing doctors because I don't like thinking that I can be sick. We get kind of proud about that. But when I'm in the hospital and they listen through my shirt for my heart, I'm thinking, are you just going through these medical students, I say, are you just doing that to make me think that you're doing a good exam? And I open my shirt and I say, here, this is where my heart is. Listen there. And so I try not to do it in such a demeaning way, but I want them to know they should do everything right. Even if it only takes 5 minutes to do the exam.